But having said that, we're gonna transition into the real experts on this subject. And it's my pleasure to introduce my good friend and one of the leading evangelists on direct primary care, Dr. Chad Savage.
As I make that conversion, actually I got it over here, real quick, I can't speak for the other members of the panel, but I would like to say, in my own opinion, I hope that we turn on some lights tonight. Every time we do this very foreign concept, that we could get away from using insurance as the only vector through which we get our health care. And my hope is, if we turn some lights on tonight, that you guys go and talk to your friends, and you turn other lights on. And I personally, and I would assume the other members are probably would as well, if we can get enough people, we fill these halls, we'd be more than welcome to come back around. This is so much bigger than any one of us. But anyway, thank you very much for coming out tonight. I'm really thrilled, and it's my honor, my sincere honor, to have the chance tonight to first of all describe why a change is needed in healthcare. And Senator Colbeck went into that a bit. What direct primary care is, and then also how direct primary care doctors are working and striving in other ways to save you money and get you better care beyond what we can even accomplish in the primary care field alone. So I'd like to start by asking a simple question. What should the practice of medicine look like? Well, in our insurance-based healthcare system, physicians are overworked. The average physician, I see nodding heads, I know immediately we have doctors here who sympathize. The average physician in the United States, primary care, has a patient census of between 2,500 to in excess of 4,000 patients per doctor. And that's ridiculous. You cannot give good care to that many people. And what that manifests as is long wait times to get into the doctors. In the state of Michigan, the average wait time from the phone call to your doctor's office to when you can come to see them is 19.5 days. That's something called time rationing, meaning the person who gets the care is the person who's willing to wait long enough to get the care. Now let's say you called your doctor and you waited almost 3 weeks to get in. Now after all that waiting, you get to wait some more. They've shown that in the United States, we waste $52 billion a year waiting at doctor's office waiting rooms. In opportunity cost. Opportunity cost is the value of your time if you were doing something else. Going to work, beautiful sunny day, out with your family. You probably have much better things that you would like to do with your time than hanging out in our waiting rooms. And we have nice monitors, and they have little videos, but that's probably not where you'd want to be. Now, after all that waiting, you are ingratiated with 8 to 13 minutes of that doctor's time, because that doctor is overworked, running room to room, fast, gotta get in, gotta get out, get to the next patient. And sadly, studies have recently shown that those doctors are distracted. You're not even getting that full 8 minutes. A recent study showed that only 20% of doctors' time is spent meaningfully interacting with their patients. 40% is spent on documentation. So if you think about that, that means a doctor is spending twice as much time documenting your visit as actually doing your visit. And that's because of the ridiculously onerous rules and obligations, unnecessary levels of documentation that they are required to do to get their payment. But it doesn't end there, unfortunately. How we finance our system, which is called the third-party payer system, it was our money, folks. You took your money and you gave it to the insurance companies and you gave it to the government, and now you're hoping that they give you some back in the form of medical care. But how that is reimbursed has become so convoluted that your doctor could actually make more money by denying you care. And that seems like an outlandish claim. I'm happy to expound on that for anybody who's interested. But for really quickly, one example. There's something called high-tech utilization ratings. This is considered a bad thing to the insurance companies, and I'm not trying to vilify them at this point in time. The high-tech utilization rating, and basically that means if a doctor orders an MRI on you, that doctor is considered a bad doctor, irrespective of whether that MRI was justified or not. The sheer fact that they ordered it increased your cost of care. That goes to about a third of the rating of that doctor, quality rating, and that doctor actually gets dinged for having ordered what may have been an appropriate test for you. That destroys the doctor-patient relationship. How can you trust what your doctor tells you when they can be incentivized to deny you care? So I have not found any graph that I think more succinctly illustrates what has happened in our healthcare system than this. To explain this, this brown line here is the number of physicians in the United States over a 4-decade period of time, from 1970 to 2009. And as you can see, it's relatively flat. There's a slight increase, but it's a largely stable supply of physicians. The yellow is the number of physicians that are listed as healthcare administrators within our system. This is bureaucracy. There has been a veritable explosion of bureaucracy in the healthcare industry. The black line is the per capita spending in the United States. Per person, how much each person spends on medical care. And as you can see, that trend line much more closely approximates the explosion in bureaucracy than it has anything to do with physicians. And the physicians in the room probably understand that we have been vilified. We have been told that we are the reason the system is broke, we are the reason it is so expensive. Then I would say that this very much argues against that. And what you don't see is that this ended in 2009. Senator Colbeck was just referencing a small little bill, I think it was on a page or two, that passed about that time that really changed our healthcare system. I would argue that since that time, it's probably done more like this. So this doesn't even reflect the expansion of bureaucracy that has occurred recently. And this manifests itself as the 800-pound gorilla of the third-party payer system that accompanies every doctor, every day, into every exam room. And the gorilla of the third-party payer system, how we finance the system, is carrying the piggy bank. And with that piggy bank, they can control, and I'm not trying to vilify them, this is just the way the system is designed, they can control that doctor like a marionette and indicate how many patients they need to see, how fast they have to see them, how many topics or issues they can address, and even dictate the type of care that we as physicians can provide. Now, I wouldn't bring up a problem unless I thought there was a solution. And part of that solution is direct primary care. Now, what is direct primary care? Direct primary care is a membership model of primary care. It's a low-cost, monthly, quarterly, or annual membership that's predictable, budgetable, it's affordable, and it's a direct relationship. It gets this out of the way. And just like Senator Colbeck had on one of the slides where it was the doctor and the patient, it restores that historic relationship of the doctor working right for the patient, and it gets rid of those conflicts of interest and restores the patient to the center of what we do. It gets rid of the billing hassles too, and the conflicts of interest, as I mentioned, as well. Because again, there are no charges when you come in to see a direct primary care doctor. This is incorporated all within the membership model. It's a wrap price. When you go to McDonald's, you buy a hamburger. You don't pay more to get the napkins. McDonald's wrap that into the price of the hamburger. We don't get that in medicine. We nickel and dime, and again, I'm not vilifying those of us who have to do it. We have to nickel and dime for every little thing. Did you do the urinalysis? Did you charge for that? Did you get the billers and coders to address all these issues? We say, well, just wrap it into one predictable amount. Don't waste your time. It takes more time and effort and resources to bill a 10-cent urinalysis than to just wrap it into the price. McDonald's can do it with their napkins. We can do it in healthcare too. Most direct primary care physicians have smaller practices. This is by design. Most limit it to under 1,000 patients. I'm probably capping mine about 700 to 800. People look at that and they go, but didn't you just say about 3,000 patients are with each doctor in the insurance system? That's an anomaly. What's wrong with you direct primary care doctors? This is the historic norm. Prior to 1980, the average doctor saw about 1,000 patients. We are not the anomaly in the direct primary care world. What's occurring in the insurance-based world of medical care is the historic anomaly. It's just occurred gradually over decades, over several decades, so people don't even realize how broke it is because of gradualism. What this allows for is improved accessibility. Because your doctor has a reasonable number of patients, it allows for things like same-day visits. You no longer have to wait 3 weeks to get in to see your doctor. If you were sick, we try to get you in. Why is that important? Because that decreases ER utilization, the single most expensive place for you to access care. Your doctor should be able to be there for you. The reason they cannot is because they have too much thrown on top of them. This helps correct that problem. And then not only are you able to get in a timely fashion, but your doctor is able to address your issues. Gone are the 8-minute visits, unless you really only need 8 minutes. Primary care doctors, direct primary care doctors tend to schedule in 30-minute and 1-hour increments. This allows ample time for you to address all the issues that are concerning. It's patient-centered. There's a lot of patient-centered nomenclature in medical economics right now. Patient-centered medical home, patient-centered this, patient-centered all that. But once you look beneath the title, that's where it all ends. It's all payment-centered. Oh, you get an extra 0.5% reimbursement if you do that, or we're going to decrease you 0.25 if you don't do this. All of the patient-centered, all the various contracts that doctors have are all surrounding the payment model. So that's actually our current system is not patient-centered, it's payment-centered. This goes back to the patient being the center of what we do. And it allows for innovative delivery systems. Doctors are currently shackled by how you bill things under what are called CPT rules. We have certain guidelines, we have to do certain things to get reimbursed, and that actually stymies innovation in the healthcare sector. By working directly with our patients, we are allowed to innovate, and I'll come back to that. So what does a membership model look like? Well, in that low-cost monthly membership, it includes all office visits. I jumped ahead. All right, all office visits. Now that's really, really, really important. Studies have shown that if you increase co-payments, even by a small amount, people don't use their primary care doctors. Well, that does decrease costs, spent on primary care doctors, but what it also does is explode hospitalization costs. Because people are so scared to come to their doctor that when they eventually do present with an illness, it's in a much more advanced state, they're much sicker, and they end up in the hospital, which is exceedingly expensive. And that, obviously that takes a financial toll, and we're mainly focusing on the cost, but that is a human toll. That is people's lives that are affected because they can't afford their doctor. Our patients in direct primary care, they don't even worry about that. They already paid us the membership model. I always tell them, if you come in, I'm so sorry, I forgot my wallet. I don't care, I know who you are, you're compensating me. Come on in, we'll take care of you. Because we don't even worry about the money. Doctors don't like talking about money or thinking about money because it seems unseemly. Gosh, I'll pay care for you if you give me $200. We don't like that. Most of us did not go to medicine for that purpose. The best way to stop thinking about money is to talk about it once. Here's our low-cost monthly membership. Does that sound good to you? Great. Okay, we're done talking about money. How can we take care of you? It includes all in-office diagnostics that you would do in a standard office visit. Person comes in, needs an EKG. Great, it's on the house. It's included. It's wrapped price. You need a spirometry, wrapped price. Pulse oximetry, wrapped price. Holter monitor, wrapped price. The doctors in the crowd know that those are expensive tests. Holter monitors are a 24-hour EKG monitor. $350 is the standard bill rate on that. All in-office procedures, knee injections, basic biopsies, cryotherapy, ear lavages, and what I think is going to revolutionize the practice of medicine, what I call virtual home visits, commonly known as telemedicine. What is that? That's email, text messaging, Skype, phone calls. Our current insurance-based system has not even fully recognized the phone. That is not a new technology. It is interesting how lagging they are on that. There is actually a code, so theoretically you can have a phone call with your doctor, they can bill it, but almost no one compensates for it, and the documentation requirements that you have to do to put into that exceed the value of even bothering. So doctors are, again, not bad people. I was insurance-based as recently as a year ago. Great people, great doctors. They can't practice the way they want to because of the way the system is designed. We get around that. So what is a virtual home visit? And we were actually just talking about this just a little bit ago. Here's a classic example. Imagine it's a Saturday morning, and you wake up and you've got this itchy rash, and it's driving you nuts. You're like, oh God, I was in the garden yesterday, and I saw that poison ivy, but I didn't think I got anywhere near it, and oh boy, this is terrible. My gosh,
gosh, maybe on Monday I'll call my doctor and see if I can get in. Wait a second, I heard Dr. Savage say it's average in Michigan is 19.5 days to get in. And oh gosh, I'll be lucky if I even get in the same week. Oh, I can't take this anymore. I'm going to the ER. Most expensive place to access care, ERs. In this model, forget about it. Pull out your cell phone. Take a picture of it. Text it to your doctor. Hey doc, I got an itchy rash. I was in the garden yesterday. I think I got poison ivy. Why, that does look like poison ivy. Let me send some triamcinolone cream in for you. Hope you feel better. Let me know if you don't. Good, easy, convenient, cost-effective. And think about it. From a doctor's standpoint, good care. I got a history in the garden, got an itchy rash. I got a physical, I got a high definition. The cell phones today are incredible. High definition picture of the rash that is actually incorporated into my record system. I got a treatment plan, try some triamcinolone. I got a follow-up, let me know if you're not feeling better. Quick, easy, good. Great for the patient, good for the doctor. You know who else it's good for? The really sick person who wasn't even there. Because by allowing that doctor to handle things through the convenience of technology, on Monday, when the really, really sick person who needed to get in and see us, who needed more time, they got it. Because we are not now on Monday wasting our time. I don't mean this is a waste. This person needs care. But we're not wasting it in person, wasting that person's time, dragging them from work, taking time that we didn't need to evaluate something that could easily be handled through technology. We now have that extra time to give to that sick person who really needed us. So it's good. It's the beauty of allowing doctors the ability to, with their own discretion, determine what is the best way for us to allocate our precious time resources. Nothing more precious than time. Ask somebody who's got a week left to live, what's their most precious asset? It's time. So, now we don't really end there. That's the general idea of direct primary care. I'm trying to be somewhat quick. I have a tendency to run on, and I didn't have my timer, so I have no idea if I'm running over. So we combine this with massive discounts on cardiac diagnostics, imaging, laboratory testing, generic medications, vitamins, and over-the-counters. We have gone to our peers in the community and said, hey, Mr. Specialist or Imaging Center, if I got patients I can send you and they want to pay you cash at the time that you do the service, would you be willing to say no? Most of them jump up and say, yes, oh my God, I'd love not to have to bill and code and do all those things. They love it. They give us great prices. So we go out, we tell them that this is available, they give us prices, we pass them on to our patients. Now I got to say real quick before I move on that, you don't have to use these. These are things we've developed to make high deductible plans much less scary and much more affordable for people. But few people are in this false belief that if I need an MRI, I better have a platinum plan. I better spend 20 grand on my insurance product in case I need that MRI. Well, we make it so that the cheaper insurance is much more appealing, and you can save thousands by doing so, by choosing the less expensive insurance. And as you'll see in a second here, not be hurt by doing so. So let me give you some examples. MRI. According to healthcosthelper.com, in 2014, the average bill rate on an MRI was $3,461, and trust me, I've heard worse than this. We have been able to get MRIs for as low as $275. In fact, that's out of date. I've now recently got one that was $240 was an MRI of a knee. That's a savings of $3,186 on one test. On one test. And as you'll see in a minute, with the savings you get on one test, you could have seen unlimited your direct primary care doctor for many, many years. Many years on the mispricing of one test. Stress echocardiogram. Average bill rate on that between $1,100 and $3,000. We're able to get them for $207. Savings of over $1,800 again on one test. Many years you could have seen your direct primary care doctor for the savings on this one test, which is interesting too, because some people go, well, what if I'm healthy this year? What happens? Well, you only need to be sick every once, like many, many years for us to have saved so much money for you that it makes it all worth it. Chest x-ray, bill rate $460. We're able to get chest x-rays as low as $33. On a chest x-ray, that's a savings of $327. Now this one is a personal one for me. It drove me nuts. Talk about time allocation. The doctors, again, probably understand this. I spend hours filling out forms for insurance companies trying to justify diabetic testing supplies. They're diabetic, they're on insulin. Can't you just accept that and claim? No, we have to fill out all these forms, beg and plead. Hopefully they approve it. So I finally said, I wonder what these things actually cost. So I went to Walgreens and I looked at their generic brand, okay? I did not try to create ridiculous numbers just to inflate how much we can save people here. This is all on their website, you can verify any of this. 100 test strips from the Walgreens generic brand and their monitor is $98.97. I can get a name brand monitor and 100 test strips for $18.48. What we do is a Costco-like structure. We try to maximize what we can do with our licensures. We buy directly from the distributors, we tack on shipping and handling, and we sell it to our patients at no upcharge. We give that to the patient at our cost, which you can never do on your own. So we try to maximize the benefit for our patients. That's a savings. If somebody's testing 3 times a day, that's a 1-month supply. And I'm sorry, it's kind of faded out here with the lighting. That's a savings of $80 every single month just on diabetic test supplies by your doctor being able to do what they can do. Gabapentin is a neurologic pain drug. According to Hippocrates, which is a reference guide for doctors, a 1-month supply of gabapentin is $130. And by the way, I have found this a little cheaper more recently. But how much can we get it for? We have an in-house pharmacy. We can buy from the same distributors that Rite Aid and CVS do, or we just dispense them to our patients and give them no upcharge on that, just cover the costs. We can get a month supply of that for $4.37. For somebody who's on gabapentin to control pain, that's a savings of $125 every single month. Last one. Okay, sorry. And I'm sorry, and I'll get moving here. So blood tests. We do blood tests too. We get direct relationships. We can give you the cash pay rate. CBC. White cells, that's immune cells. Hemoglobin, hematocrit, that's looking for anemia. Platelets, these are your blood clotting cells. Bills at $85. We're able to get that lab for $3.13. That's a savings of $81 on one test. As most of you know, doctors order panels of tests. We don't order one test. So if you order 5 tests, you can do the math. All right, just a quick view. I'll let you guys, you can see most of this. These are examples of our in-house pharmacy. We can get a month of Zocor, which is a cholesterol medication, for 72 cents. Flonase, I was laughing, I was at a local retailer, and they had it on sale for 23 bucks. We can get it for $4.90. Flu shots we do for $9.99. We can get a month of lisinopril, which is a good blood pressure medication, for 39 cents a month. The markups on these things are ridiculous, and I've been giving an evil eye, so I gotta go quick. So how much does all that cost? Anybody want to harbor a guess? What would a membership like that cost? All the visits, all the procedures, all the diagnostics, telemedicine, better access, no conflicts of interest, discounted meds, labs, imaging, etc. We can do it as low as $39 a month. Now the doctor's going to say, wait a second, how can you do it at those rates? That doesn't make any sense. So I'm going to show you quickly what I call DPC math. So in an insurance-based model, if you bill $1, you are lucky if you collected 60 cents on the dollar. That means you only collect 60% rate, which means you only collected 60 cents on the dollar. But the collection of that 60 cents was not free. At least 40% of your costs are likely wrapped up in the collection of the 60 cents, which means from the dollar you originally started with, only 36 cents is actually going to your medical care. Now let's compare that to a direct model. Got all the bureaucracy out of the way. You charge $1, it's payment at the time of service. You have essentially 100% collection rate. So you charge $1, you get $1. The collection of that dollar, we usually use credit cards, 2% credit card transaction fee. That means of the original dollar, 98 cents is going to your medical care. That is 3 times as much as you get in the insurance model. This is how you can give good rates, see fewer people, give them better care, make it affordable for people. It does not hurt the doctor, it helps the patient immensely. And I'm not going to go extensively into this because this is what Teresa's going to do, but because we are able to get such great prices, we work extremely well with high deductible PPOs, with Christian-based health sharing, and I asked Teresa if it was okay if I show you one slide, and she said okay, so I'll take her word on it. Christian-based health sharing, there's one that you don't have to be Christian to use, which is ironic. And ERISA-based self-insurance plans, these are companies that make their own insurance models. So just to reiterate, so this slide basically just says, again, direct primary care, low-cost monthly membership, direct relationship, all the visits, all the in-office diagnostics, all the procedures, telemedicine, discounted labs, it's too slow, discounted meds, imaging, but in its essence, direct primary care is doctors being doctors again. Such a beautiful thing. Which brings me back to my original question. What should the practice of medicine look like? So thank you. My one slide I'm going to show you beyond this is just non-insurance. These are Christian-based health sharing plans. When you look at these, this is one you don't have to be Christian to use. This is essentially your premium, or if you're under 30, this is essentially your deductible. Similar, they are not insurance. They get real persnickety if you call them insurance. But the beauty of this one is this is what they would kick in towards a direct primary care membership if you had one, which means if somebody's paying $199 here, none of our prices exceeded $60 except for if you're over age 70. So that means for $199 you have your ACA compliant coverage option and unlimited direct primary care all in that price. So thank you very much.
Good question. Hospitals and doctors recognize Liberty Direct and they believe they're going to get paid?
They do. It's a growing thing. Usually if you go to a specialist or something, many of them have not heard of it. So there's a couple of options. Ones who have, they cover it directly. I actually had somebody get a colonoscopy, screening colonoscopy recently covered by Liberty Direct. And they had no issues. They paid the doctor directly. The patient wasn't even involved in the transaction, which is great. However, there is a chance you may have a doctor who says, no, I don't know what that is. It sounds like a scam because it's still growing in acceptance. You can pay it and then you submit the claims and they pay you back.